Welcome, everyone, and thank you for joining us today. My name is Bill Manning, and I'm Executive Director of ASPI. Quick footnote, I have been on active surveillance since 2009, and I am still a member of my local support group that got me started on this journey. Our purpose here is to educate individuals about options regarding active surveillance, which is not a treatment but a management plan. I would like to remind everyone that we are not anti-treatment, we are anti-unnecessary treatment. We are not here to dispense with any medical advice. Nothing said during these meetings by our speakers, ASPI, or the audience should take the place of consultations with your medical professionals. We are going to hold all questions until after the speaker's presentation. You can submit questions in the chat box, which we will try to address. Please keep your questions limited in scope. Our speaker does not have time to review your medical case history. Also, at that time, you can click the raise hand button from the bottom of the Zoom window toolbar, and if there's time, we'll try to call on you. During the meeting, please keep yourself muted. The speaker presenting today is generously donating his time, so we want to be respectful of that. This meeting is being recorded and will be available on our website in approximately 1 week, and you'll get an email notifying you when it's ready. Also, if you subscribe to our YouTube channel, you'll automatically be notified when a new video is posted. So I'll quickly add here that we are always looking for volunteers. So if you have some time to help spread the active surveillance word, please get in contact with us. We also appreciate your donations. No amount is too small. So if you can share, please go to our donate page on our website. So without further ado, we'll have a few quick words from Mark Lichty, our chairman, who will then turn the meeting over to Howard Walensky, the organizer of this meeting, to introduce our guest. So relax, enjoy the meeting, and I hope you leave a little bit smarter. Take it away.
Thank you, Bill. I want to welcome you all here. Bill made a pitch for volunteers, and I'll tell you, when we founded this organization, Active Surveillance Patients International, there was no organization that was doing this important work. And for me, it's been one of the most rewarding things I've done in my life. So, um, I think you'd have the same experience. And I wanted to focus on the particular need. We struggle to keep active surveillance patients international funded, and we always need fundraising skills. Now, you don't have to have been a professional fundraiser, but boy, we could use your skills in that area. So that would be a particular need to look at. I mentioned earlier before you all came in that last month we had people after we ended the meeting that hung around, and so we decided that people liked to talk and further the discussion. So we're just going to hang around after we close the meeting today. We'll hang around for you, and uh, so it might go a little longer if you want it to. It's up to you. You're welcome to join us. But with that, I'd like to introduce Howard Walensky.
So I guess I take over from here, Mark, right?
You're on. Yes.
Okay, well, we're honored today to have Dr. Brian Helfand as our speaker on BPH. What's new and what's up with it? Now, I have a disclosure. Dr. Helfand has been my personal urologist 10 years next year, and he's kept me on active surveillance. I've been on it for 15 years now. And I'll give him a plug. He's a great doctor. And I look forward to seeing him, but no more than once a year. To me, he's the model of a good doctor. He takes his time, he listens, he answers honestly. He may not always have good news for you. And by the way, I don't always agree with him. And I've been pleased to see that he's grown in his practice and went my way. So, but a little bit of his background. Brian Helfand is chief of the Division of Urology at medical group now called Endeavor. I wanted to call it North Shore, and that's how it's been until recently. He is director of the Personalized Prostate Program, director of Clinical Research Program, I guess at North Shore or Endeavor, and he's also a clinical professor at the University of Chicago. He holds not one, but two terminal degrees. He's got an MD and he's a PhD in cell and molecular biology and genetics from Northwestern's Feinberg School of Medicine. Actually, the reason I switched over to him was in large measure his expertise in genetics. I just felt that my own doctor didn't necessarily know, my second doctor didn't necessarily know what I wanted to know about genetics. And so Brian is, as a molecular biologist and a urologist, has helped develop some new tests for genetics and prostate cancer. He has authored over 180 peer-reviewed manuscripts. I'm not going to review them. And he's not only about prostate cancer, though oncology was his first love, I guess. His second was BPH. Strange lovers, I have to say. His research on BPH includes development and early adoption of innovative therapies such as Aquablation, which I'm sure he'll talk about today, minimally invasive robotic water jet ablation procedure, that's Aquablation, designed to relieve urinary symptoms of BPH while preserving sexual function. He is an active participant in several other studies and multi-institutional collaborations in this field. So when he tells you, he's telling you the truth. So, and one of the first things he tells you as a patient is, call me Brian. So I'm going to call him Brian. You're going to have to fend for yourself. But Brian, it's your turn.
All right, that's great. And certainly the reason why Howard is only showing his upper half is probably because I've been taking care of the lower half and you don't want to see that. So it is good. But let me share this here. So hopefully you guys can all hear me, but I'm kind of a unique urologist in that, as Howard alluded to, that my passion is really towards understanding all aspects of the prostate. And I am urologically oncology trained and certainly have a really, I think, a evolving and a true appreciation for all aspects of prostate cancer care, particularly in active surveillance and using genetic and novel biomarkers along the way. But I've always said that you really need to understand the true function of the prostate if you're going to treat people with that. And most men will experience the usual I guess, blessings of the prostate, and that is that it does contribute and influence a lot of our urinary behaviors and habits. So I think because of that, I fall into a very kind of unique space, especially for an oncology trained urologist. And so really, I want to go through and introduce this group to really the main function of the prostate, right? And how it really enhances and ultimately contributes in a bad way to the development of urinary symptoms by enlarging over time. And so, again, as this group knows, is that the normal function of the prostate, why we need it, is for sexual reproduction, right? It produces the fluid that keeps the sperm happy. But after reproductive years, it goes on to grow, something that we call benign prostatic hyperplasia, and give you increased urinary symptoms. And so, how does that, kind of affect where you guys are, especially in with cancers that we're not treating? And so again, many of you are just like the benign kind of average guy that we're aging and we get those urinary symptoms. So what are urinary symptoms, and why do we all complain about it? Why is it kind of a joke as we age at the urinal of saying, hey, it's taking you kind of a while to finish your stream. Why is it taking you so much longer than the 20-year-old? And so understanding that, what they are and what are signs that, you may have a problem. And by problem, I mean, kind of what is the bother to your life, right? For the most part, if you develop urinary symptoms, it's just a quality of life issue. This is not cancer. This is truly because you are using the bathroom more frequently. So again, these symptoms that I'm referring to are getting up in the middle of the night, something we call nocturia, right? The average number of times to get up in the middle of the night is 2 or less as we age, right? So if you're more than that, and that's certainly affecting your sleep, or that's causing you to get up and you need to use a urinal by your bedside, you may have an issue that can be helped. Nocturia, that getting up in the middle of the night, is the most bothersome of all symptoms. When you query men and you say, well, what drives you the battiest out of all of this? It is truly that getting up in the middle of the night. But often those daytime symptoms, including increased urinary frequency or urgency, like I got to go to the bathroom, I got to go now, or a weak stream, are things that we notice. But don't necessarily have the same degree of the bother unless they get severe enough where you sometimes can leak urine, right? So this is if you cough or you sneeze, which is rarer in most men, but is more common if we took your entire prostate out. If we have that sense of urgency, I gotta go, and then it starts leaking, or we dribble urine, all of this kind of stuff. So these are things that affect all men as we age to varying degrees. But again, as guys, we're kind of, as they say, women are from Venus, are from Mars, men are from Venus, whatever that is. But it's really because these are very slow to occur over time in the vast majority of men that we often neglect them, right? It's that slow kind of strangulation of the bladder that occurs over time. So by the time we seek care and we bring it up to um, a primary care doctor or a urologist saying, like, I'm having these problems, it may already been that you've had this for a long, long time, because that tends to be, we tend as a gender to be a little bit more lackadaisical in terms of bringing this up. But certainly, I bring these symptoms up to your attention because if you notice them and they're saying, hey, it's affecting my quality of life, or I am seeking, alternatives. I'm keeping a bin or a bottle in the car so that when I pee and I have that urgency, I got a solution. Those are avoidance behaviors, right? I always have guys who say, well, I know where the closest bathroom is at any place I go, or I'm on the golf course and I'm going every hole. You may have an issue, and most of these are easy to deal with. But when we look at what is the etiology, what underlies the development of urinary symptoms, it's very complex. It's not simply that, hey, every man has an enlarged prostate, and because of that, I'm going to go to the bathroom. But an enlarged prostate, BPH, benign prostatic hyperplasia, is the most common, contributes to most of our urinary symptoms as a stereotype. But as you can see here on the list, there are so many other things that can cause us to use the bathroom frequently. And on this list, I do think that if you have diabetes, that definitely contributes that. Diabetes, so sugars, uncontrolled, can influence the nerve supply to our bladder and cause us to go more frequently or urgently. Sleep apnea, if you snore or your partner says that you stop breathing in the middle of the night several times and wake up, etc., that may be why you're getting up during the night, and it may be why you're during the day using the bathroom frequently. So there's a multitude of reasons why you may have urinary symptoms. And certainly, as I talk to other urologists and primary care doctors, emphasize that you should assess a patient for the presence of all these confounding things that contribute. Because if you address all of these things, if a patient has them, your ability to improve urinary symptoms at the same time you're addressing their BPH, their enlarged prostate, is going to be better. Of course, one of the things I bring up here is it is a stereotype, right? If you go online and you say, what are the symptoms of prostate cancer? One of the first things that you will see is that you may have increased urinary symptoms, or you may have a weak stream, or you can't pee, etc. So I often have patients come to my office and say, well, I'm having urinary symptoms. I'm dying of prostate cancer. And I always say, no, no, no. Certainly that still can happen. Back in the 80s, that was a lot more frequent as a possibility because we didn't have a screening tool to evaluate for the presence of prostate cancer, PSA. But in the modern era where we're screening, as long as you are getting screened appropriately, yes, you can develop urinary symptoms related to prostate cancer, but in general, most men with prostate cancer, especially men who have a lower risk type prostate cancer, never go on to develop symptoms because of the cancer itself, but still more likely it is confounded by just the average growth of the prostate, BPH. And so, I think when you assess men with prostate cancer, it's important that you assess for all of these confounding factors that contribute to urinary symptoms. But on the other hand it was at one time thought that men who have an enlarged prostate, who have BPH, who seek care from a urologist because of their urinary symptoms, are at increased risk of being diagnosed with prostate cancer. So it was thought, and that there was an association, but it was more because men were seeking care and they were more likely to get screened and then subsequently diagnosed with prostate cancer. But the truth of the matter is that there is actually a shared genetic predisposition. So there is, and this goes back to what Howard was inferring to, there is a commonality in the genetics underlying BPH and prostate cancer. So again, there is a slight overlap, but about 10 to 15% of guys will develop, or I say are lucky enough to be diagnosed with both urinary symptoms independently as well as prostate cancer. And so I'm not going to spend a whole lot of time with it. I think for this group, it's just kind of interesting is that, our research group and others have spent a lot of time trying to discern what that, kind of common genetic predisposition is. There is not a shared, gene like BRCA. I think that several weeks ago you heard about various genes that contribute to prostate cancer and aggressive prostate cancer. There is not that type of single gene mutation that contributes that can explain BPH and enlarged prostate as well as prostate cancer. But rather, if you look at these little blips throughout the DNA, these are the single nucleotide polymorphisms. This is what I've spoken to this group before about, is that these little blips do increase the risk of prostate cancer. And there are others of these little blips throughout every man's DNA that are also increase your risk of benign prostatic hyperplasia, or BPH. And we have throughout time identified many of these blips, if you will, and we can count them up. And again, we can create scores, genetic risk scores, polygenic risk scores, which again, I think you've heard about. There are polygenic risk scores that we can use to actually estimate a man's risk for prostate cancer. And there are other ones that we can estimate that for BPH. And again, they're very simple to interpret. If you kind of average it to the population, and for prostate cancer, as an example, if you had a polygenic or genetic risk score of 1, that's average population risk. If you had a score of 2, that means you're twofold higher than the average population risk. So it can actually independently estimate your risk of either of these prostate diseases. And again, just emphasizing a lot of the work that has been done. And we've looked at, now hundreds of thousands of men with BPH and those without BPH. And there are, novel of these blips that you can use to estimate your risk of BPH. And there are other ones, as we've talked about, that for prostate cancer. And so our group has really evaluated that and said, well, how many of the population? So if Howard comes into my clinic and I say, well, what is your risk? Even before I knew he had anything here, we can use this to really estimate who's at risk of prostate cancer, who's at risk of BPH, and who's at risk of both. And as you can see here on this pie chart, more than anything else, is that, there are those lucky individuals that are genetically predisposed to both prostate cancer and BPH, those with BPH only, and those with prostate cancer. And again, not getting into the weeds here, but that can be useful when you have a man who presents with an elevated PSA. Again, that PSA blood test we know is plagued for many reasons, but one of the biggest confounders of the interpretation of PSA is because it becomes high, not because of a cancer, but because of an enlarged prostate. And we can use that to kind of help sort out who's at risk or not at risk of the various, if you will, diseases of the prostate. This is not considered standard of care at this time, but again, just letting this group know is that because there is such a genetic predisposition to both prostate cancer, a separate genetic predisposition to BPH, that we now have some understanding of that, and we can help sort out who is who even before this journey begins. So when you have a patient who comes in with urinary symptoms, as I said, is that you have to make sure, that nothing bad is happening. So you want to rule out or at least screen those men for prostate cancer. And once you kind of rule them out, then you can really focus in on, kind of their urinary symptoms and the BPH. So that's, again, you want to rule out badness before you focus in on something more quality of life like BPH. And so, BPH has really been described over time. And as I said, is that after reproductive years, that prostate goes on to do nothing good for any of us because it continues to enlarge. So if you look on this kind of black and white graph on the left, this is from Don Coffey at Hopkins, who is, since passed, is considered really a true innovator in BPH and prostate research. But what he really did notice is that there's, kind of an average growth that occurs in most men. And you can kind of see that. But with age, that prostate is going to get better. And based on that he said is that based on that growth rate, and you look at who is getting surgery or intervention for an enlarged prostate, at one time they said about 25% of guys will ultimately need surgery to help with their benign growth of their prostate causing their urinary symptoms. So again, this is a huge issue among men. But it's not the whole prostate that grows, right? Is that, and I don't know how familiar this group is, but if you consider the prostate in orange, I always think, again, I think Howard even wrote about this once, is that for some reason we always like to compare the prostate to fruit. But considering that if you can compare the prostate to an orange, the juicy part in the middle, the part that we eat, that is the part that enlarges over time, that grows. It's the peel that generally stays the same. We call that peel the peripheral zone. Unfortunately, that peel is the one that is most susceptible to prostate cancer. So about 90% of prostate tumors will form initially in that peel. But most of the, kind of juicy part, most of that prostate, especially with age, is that transition zone. And that, again, a complex slide here, but that is the part of the prostate that continues to grow with time. And again, that growth isn't the same for all men. There are certain overachievers, right? That, God, you have a huge prostate, it's several hundred grams, and you're only 50 years old. And there are, guys that are just kind of just puttering along, and there's more of a slower growth over time. And so it is one of those where everyone is somewhat unique in that space. And so if we look at our guidelines, and this is kind of changing topics a little bit, but if you see a urologist and he says, well, you know what, I need to assess how bad your symptoms are. You're coming in with urinary symptoms. We should be quantifying this in some way. And so I think, Howard, you're drawing on the screen a little bit, but we like your scribbles. But the ultimately, we use a standardized questionnaire. It's called the International Prostate Symptom Score, or IPSS. I think many guys over time have called it the IPIS score. So it's a little bit of irony that it is the validated questionnaire that is in all guidelines that you should be filling out, I believe, at every visit when you see the urologist, to assess not only the severity, how, if you have the presence as well as severity of symptoms, do you go to the bathroom at night and how many times? And then it also has a question regarding the bother. So this is the actual questionnaire that hopefully many of you guys have seen, that is we use to assess the presence and severity of urinary symptoms. And then again, it always says is that if you had to go the rest of your life in this way, are you okay with this, or would you want some type of intervention? And that's really the most important thing that I believe, is that there are men who go to the bathroom very frequently and they're okay with it. And as long as they're not having problems like urinary infections or bladder stones or kidney failure because of it, it's okay. But if you say, hey, I'm bothered by this, we can intervene. Now, this symptom score was the first of its kind to really be developed. It was really kind of published and validated very rigorously in the early 90s, right around the time that PSA was coming on board. But on the other hand we haven't really evolved. And it turns out that this questionnaire really lacks a lot of important things, right? It doesn't ask about if you have any leakage. Well, leakage, it turns out, is the biggest bother for most men. It doesn't ask about pain. It doesn't ask if you dribble or anything like that. So I'm part of a national group called the Lower Urinary Tract Symptom Network, or LEARN. And several years ago, we really worked to update this questionnaire. And so now there is a more informative questionnaire that does include a lot of the symptoms that are typically most bothersome for patients. And again, I don't need to get into the weeds here, But when you use this questionnaire, it really, as you can see by the red dots here, those are the ones who have the urinary leakage. Those are the ones that you can really pick out and really help to determine which men are going to really benefit from treatment because of that leakage. So it is one of those to pay attention to. Again, talk to your physician, make sure that they are asking these questions because again, this is, if you, in my opinion, low-hanging fruit where we can make a big difference. And I say this because most men at some point in their life will develop urinary symptoms. And this is, really data that comes from the Global Burden of Disease database, which is a multi-million patient data set. And when you look here, is that as we predict with time, this top bluish line is BPH, and as you can see, it is because we are living longer, because our longevity is increasing, the burden of BPH is increasing. So again, it is one of the most common things that we have that cause urinary symptoms. But unfortunately, when you look at our U.S. workforce as urologists and as people who are, kind of trained to deal with this, that isn't increasing. So if you look at the ability for urologists to meet that increasing demand over time, we currently have the workforce to be able to treat about 2% of men with BPH. So that's kind of a scary fact. Not all countries are underserved in this way. But again, because of our population and because of the current workforce in urology projections, we are not necessarily prepared to deal with this global burden. So how can we really face this? Is that, when we treat BPH, we have to treat it well because yes, we can add more clinicians. As you're seeing by all of the changes in our government right now, I don't know if that's going to be the solution. Can we do more prevention? Should we add more drugs? We haven't had a new drug for the treatment of BPH in many, many years. So, I don't even know how many are truly out there being evaluated at this time. And so certainly if we're going to treat this, maybe we can have more cost-effective treatments, surgeries, if you will, that treat it in minimally invasive ways. But when you treat it, you're done, and you don't need several treatments, even if you're living longer. So again, when you look at the overall effectiveness of our current therapies here, there are different things that we can do. And I think the most common response, to I have urinary symptoms. Well, let me just give you a drug, right? And so we're a drug nation for the most part. I'm not a big drug person personally, but it is one of those where, it's very easy to say, well, go take a pill, right? And not everyone is on board with that. But when you look at the bang for the buck, and you look at the overall improvement, it's as you can see on this top line is if you have really bad urinary symptoms, drugs, they do work, right? But they only move the bar a little bit. So again, knowing that there are better options than taking a pill every day is important. When you look at the surgical therapy, and these are kind of separated into what we call non-resective therapies, these are therapies that don't remove prostate tissue versus resective therapies that get rid of prostate tissue, kind of like the TURP or the Roto-Rooter, so to say. The surgeries are way more effective in terms of a relief of your urinary symptoms. So it is one of those where I think having patients understand that difference is one of the most important things is to say, well, now you have urinary symptoms. It suggests that it's from your prostate. What are our options here? Is that yes, we can give you drugs. You would have to take a pill every day. And those pills may have some side effects, which we'll talk about, or we can talk about surgeries. If we talk about the effectiveness, certainly any type of surgical intervention as a one-time deal to come in, get a therapy, you're done, is going to give you a lot bigger bang for your buck. And again, when you look at the overall medication, and again, this just is why it reinforces why I'm not the biggest fan or advocate for why we need to give drugs to help urinary symptoms. There are various classes, right? So we have our alpha blockers called AB here. We have 5-alpha reductase inhibitors like finasteride or dutasteride that shrink your prostate. We have, various other medications, which I'm not going to go through. But if you look at their overall compliance, guys really don't like these, right? They start a medicine, they either have some side effects, or it turns out they're not effective. So they said, well, I tried, and therefore I'm hopeless. So the overall adherence rate at 1 year after starting these, um, only 30% of men will continue to take them. So that Flomax, the tamsulosin that you receive, a lot of people stop because they just feel like it didn't really do all that much, or they're having some issues there. And again, when you look at the side effects, there are side effects to all of these. And again, especially if you're looking at the 5-alpha reductase inhibitors, the finasteride, erectile dysfunction, sexual function. We talk about, one of the beauties of active surveillance is that you avoid the possible side effects from surgery by having your prostate removed or radiation, but it's the same kind of concept in BPH. If you're going to do something, you want to limit the amount of side effects. And again, these drugs can cause, there's not all men, but you can get erectile dysfunction. It can mess with your libido, etc. So you should be aware of this. And again, this is important when you counsel patients and saying, hey, I'm going to start a drug. This is important for you to know. More recently, some of these drugs, when you look at the long-term incidence, they do have potential even cognitive side effects. So 5-alpha reductase inhibitors really mess with how testosterone is processed in the prostate. But there again, you're taking a pill, there's systemic side effects. And when you look in the long term, it does slightly increase your risk of having dementia, depression, suicidal ideations, because again, a lot of that, and there could be some confounders in the study, but a lot of that can be related potentially to messing with your hormone levels. And so again, I think it's just important to know that before you go in. And so this is really where I was asked to speak today, is to say, well, then what are my options, right? And that's really, I think, the interesting part is that there are a plethora and seemingly on an everyday basis, an increasing amount of surgical options to kind of shave down or open your prostate channel so that as it grew and it was compressing that outlet, the urethra, from your bladder, that we can reopen this and potentially turn back time, and so have you write your name in the snow, so to say. But again, because there are so many options, options are generally a good thing, but it certainly can make the playing field and a little bit more difficult to interpret. Which is the right option for me? And so that's really kind of the purpose of the rest of this, is to say what is kind of new out there, understanding that this, again, continues to be a very evolving space. So what I said is that there are many kind of non-resective technologies. These are treatment surgeries, minimally invasive, most of them, where you don't remove that, the juicy part of the prostate, but rather you just kind of open it up a little bit, right? So that is something we call UroLift. It was really kind of the prime example of that. And again, that does improve your urinary symptoms, certainly more than a medicine does. But for many men, it may not be durable, right? You may need repeat because you're not removing that tissue. But the beauty of a lot of these non-resective technologies is that there's no really influence on your sexual function. And what I mean by that is these do not cause erectile dysfunction. Actually, almost none of these procedures are associated with an increased risk of having erectile dysfunction. I cannot get an erection. But a lot of the more resective procedures do influence your ability to ejaculate. So at the end of it, your orgasms are either the same from a sensation standpoint, more intense, better, but there just may not be any fluid that is expelled. So that type of what we call either retrograde ejaculation, because that fluid now the prostate's open, so it goes back, or an ejaculation where there's just not enough tissue there is more common with the resective technologies. But the resective technologies, that's the TURP, that's Aquablation, which we'll talk about, that's the green light, that's the HoLEP, that's robotic simple, and all these kind of stuff. These are associated with a high rate, for the most part, of sexual dysfunction, but they are very durable and have a much better improvement in terms of your improvement in urination. So again, there's a balance there, and understanding that balance and difference is very important and should be discussed with you and your physician in terms of surgical treatment for BPH. So again, this is really where we have a shift in paradigm, is that we never used to pay attention to ejaculation at all. Certainly in the past, really 5 to 10 years, this has become put in our face because patients are really demanding it. Again, it's not any impact in terms of true harm, but on the other hand, from a quality of life, it's our job as physicians to really address the needs of all of our patients. And some men may not care, but even 83% of men who are not sexually active say that they would choose a procedure that preserves their sexual function in the same setting as improving their urination. So again, we have evolved in our treatment choices, and I show this because I believe the Roto-Rooter is really what people are most familiar with. I think my father really said, Brian, it's time for the Roto-Rooter, and that's really what we call a TURP, or a transurethral resection of the prostate. It is the most historic way that we have to kind of shave our prostate down. There are various nuances and advances that have happened in the Roto-Rooter over time. It used to, even when I trained, even be considered a dangerous procedure because of changes that we would induce in the salt levels throughout that procedure, because of the solutions that were used with what we call a monopolar TURP or Roto-Rooter. Again, that safety has really evolved over time. It is now very commonplace, but still remains to be the mainstay and most common therapy that we use in the treatment of BPH. Again, this is what would be called the gold standard, is the Roto-Rooter. And again, when you look at that in the blue, down below, it is the probably remains the most common. It does fluctuate over time, but that equipment that we have is present in every single hospital across this country. But it's important to be aware that there are other technologies out there, which I'll quickly kind of go through to show that, hey, there are other things that you can consider that may treat your urinary symptoms either to the same degree as the gold standard or even more. And so again, the UroLift I bring up because this is probably still remains one of the most common procedures that patients ask about. It is a very quick procedure. It can be done in the office. It preserves all aspects of sexual function, so there's no risk of having retrograde ejaculation. There's no risk of erectile dysfunction. But again, the overall improvement in urinary symptoms is not to the same degree as a resective therapy. The way that it works is it's about a 5 to 7 minute procedure. You take a camera, you go through the penis, you go into the prostate, and then you basically staple if you will, for lack of better terms, with a very fancy type of clip, the prostate open to basically squeeze that channel open, so that you make a channel large enough to alleviate some of the pressure on your bladder and make your urination that much more improved. Again, the problem with it is, and you can consider this a problem or not, is that while it preserves all aspects of sexual function, is there's just a high retreatment rate of saying, yes, I went in, I had the procedure, but you know what? Several years later, I'm back in the same boat. And that worries me, just because, again, reflecting on the behaviors of most of us guys, is to say, well, I gave it the good old Cub Scout try, but now I guess I'm hopeless, so I'm not having anything done. So again, understanding that retreatment rate, or saying, hey, I may need something else as we move forward, and as I age, is an important understanding of this therapy. Again, it's very easy to do. It takes almost no time. Again, can be done in the office, but understanding that it doesn't necessarily give you the oomph in terms of overall retreat of improvement in urinary symptoms. Certainly better than medications, but certainly not to the same degree as Roto-Rooter. A lot of people also come in asking about steam, or I've heard about a water procedure. That this is one of the water type procedures. This uses steam. So this is again, an office-based procedure for the most part, where you go in, you take a camera, you go through the penis, you see the prostate, and then you take a fang-like apparatus and you inject it into the prostate. And as you inject it, then you inject steam. And that steam then destroys that prostate tissue. So it is somewhat resective over time, because that tissue that you just heated up to the same degree as water boiling will ultimately die and slough off. It does improve urinary symptoms to a higher degree, if you will, than the UroLift, because it does resect those procedures. Because you really only treat right near the bladder, it does not increase your risk of erectile dysfunction, doesn't really have any significant risk of having ejaculatory dysfunction, so that fluid that comes out is maintained. But there is a relatively higher retreatment rate, either because the steam did not destroy the tissue that we thought, because it's hard to control where that steam actually goes, or because as that tissue sloughs, as that tissue dies, it can be really irritating. So a lot of patients who undergo a Rezūm will come in for several months and say, I'm not having the best experience right now because I have a lot of that tissue that's sloughing off. And you kind of say, well, don't worry, you'll get through this. And certainly if they do, they have beautiful results. But there is a higher retreatment rate, because some of that steam can be kind of bothersome as that continues to work and that tissue sloughs off. So again, that's really, when you counsel patients, something for them to understand and to have as a discussion point. And again, this is a steam-based procedure, not aquablation, as we'll talk about, which is another water therapy. I think HoLEP, which is holmium laser enucleation of the prostate, is something that, a lot of people have a lot of buzz about. It uses a holmium laser. This is done in the operating room. You're asleep during this procedure. They go in through the penis, no incisions. You see the prostate on the inside. You use that laser to get down to that junction between the juicy part of the orange and the peel. And then you use that laser to kind of carve out all of that juicy part. It is a very durable procedure because it's getting rid of all of that juicy part. Unfortunately, that in that process of it, about 15 to 40% of men will have temporary incontinence, meaning that for several months, 3 months, 6 months, that they will, when they cough or they sneeze, they could leak some urine as they heal after that. And that's just because as you use that laser to get rid of that tissue, you often can stretch out the muscles that keep you dry. So while you significantly improve their urinary symptoms in the long term, get rid of getting up in the middle of the night, have a stronger stream, etc., that there is a significant population that will have temporary urinary leakage. And I always put a little bit of a red flag when counseling patients about that because my cancer patients don't ever want to leak. So it's a little bit, for my practice, a harder sell for that laser enucleation, knowing that even 1 to 2% of them may have permanent urinary symptom leakage. So it is one of those where, again, in counseling this, you get a big bang for your buck, because from a symptom improvement, you get that. From a incontinence, you may temporarily interfere. And the other part about this is almost all patients, at least almost 90% of them, will have what's called retrograde or anejaculation afterwards. So it is a high risk of sexual dysfunction. And so when you look and you compare HoLEP to the Roto-Rooter, the TERP, that, some of the meta-analysis say, well, given that and given some of those factors I talked about, that, some of the quality of life may favor TERP or other type of procedures. So again, this is all part of the things that we counsel patients on, in terms of what are their goals and what is the experience in terms of healing. And so again, it's with some of that, that there is a continued changing landscape. And so there are other kind of newer therapies that are coming on board. Some are well established, already FDA approved in guidelines, and others are in the process of getting that. So Optilume is another therapy, minimally invasive, generally still done in the operating room, although some reports that you can do this in the office, where you basically go in a minimally invasive fashion, take a camera, and basically blow up a balloon in the prostate. And that balloon basically stretches out that prostate and the top part of the prostate and causes it to rip a little bit. And the special thing about this balloon that's part of Optilume is that it also releases a drug, Taxol, that basically prevents scar tissue from forming. And so it kind of keeps that open over time. And certainly the results of this really show that there is, for certain men, generally smaller shaped prostates, that are under 80 grams, that there is some effectiveness. And certainly this is the 1 year data. There are 5 year data showing that this can be an effective treatment for men with smaller prostates that can be done in kind of a more limited and rapid fashion. Again, no incisions, no change in sexual function, so it doesn't impair your erections or your ability to have that fluid. There is a lot of hoopla these days over what we call prostate artery embolization. Again, this is a different type of procedure where it's generally done by the interventional radiologist. So your urologist would refer you over to them, and what they do is they go in generally through your groin into the big vein in there, and then they map out the vascular supply to the prostate. And the thought is, if you can disrupt the vascular supply to the prostate, you will impede blood flow and shrink that down. And so this is still somewhat invasive, but there's no incisions or anything like that. But the suggestion is that this can help urinary symptoms. There are some very controversial randomized trials of this, but that it has some success. Again, I question some of this because there is going to be a variability based on patient, because certainly, especially a lot of men as we age have cardiovascular disease, so our supply to our prostate from an artery perspective becomes more complex. So it's not a simple like, hey, I can just disrupt one or two arteries and call it a day. So there is some variability based on vascular supply to the prostate, and certainly based on the experience and expertise of the interventional radiologist there. But if you hear about this, this is another kind of upcoming type of procedure that can be done, that can help some patients. So again, it's out there. Again, I caution you because we don't have that long-term durability, and the retreatment rate, as we know, even in the short term right now, is actually quite high, about 10 to 20%. There is an increasing, again, just to expose you guys to various things on the horizon here. This is now the nitinol generation. So nitinol is a rather inert type of metal that we can use and basically to stent open the prostate. There are various prostate stents that have come into play. This one is ZenFlow, but there are about 4 or 5 others in the space. The thought is that in the office that you can use a small camera, inject a stent in, which basically keeps it open over time, that you can open that prostate channel and help you void better. So again, just to be aware that there are many stents coming into this place, but your urologist may offer them, knowing that again, most of these non-resective technologies offer the benefit that there's no impairment in sexual function, but the degree of improvement in urination may not be the same to the extent of a resective technology. So with this, I really want to focus in on aquablation. Aquablation, again, is a newer, if you will, and now it's been around for the last decade, but newer type of resective therapy, so getting rid of that tissue, and uses a water jet to do that. So understanding that every man's prostate is different. You have big ones, you have ones that have, kind of a part of it that extend into your bladder. We call it median lobe. You have small ones, but everyone can have urinary symptoms and bothersome symptoms to some degree. But if there was a way that we could validate the amount of tissue we resect during a procedure in real time, and do it in a way that also preserves your sexual function, would be awesome. And so with that, this is where aquablation came into play, is to say, hey, we can use a water jet that is robotically controlled to get rid of that bothersome part of the orange that's obstructing you, but use it and map out your prostate and preserve the part that's important for maintaining your ejaculation. And so the way that it works is it's about a 40-minute procedure. It's done in the operating room. You're totally asleep because you shouldn't move during the procedure. While you are asleep, we do 2 things. We insert an ultrasound, just like a prostate biopsy, into the rectum, and we visualize, map out your prostate on that ultrasound in real time using a computer. And it's through that we can identify your significant anatomy, how your prostate is shaped and size we see. We can see where those ejaculatory ducts come in for your maintaining your sexual function. We then take a camera, we go through your penis, and then so we see your prostate again from the inside. And on the end of that camera, there's a water jet. And ultimately, we use that water jet and we map it to the ultrasound the images that we just created, and precisely get rid of that tissue that is causing your urinary symptoms. And again, in that mapping out, we save all of the important properties of this. Why we have not used ultrasound imaging in real time for many years, I have no idea, because again, it offers that advantage that as you see it, you know exactly what you're doing, because no other procedure, whether that's the Roto-Rooter, the HoLEP, do you really see it in two ways. You can always see the prostate on the inside, but you don't really get the bigger picture of what you're doing on the outside. And this technology itself offers that advantage because it really allows you to see in two different ways exactly what you're doing. So the results are really reproducible. And again, this is just a fancy mapping plan that we can do. And you can see how, based on various prostate sizes and shapes, we can create a mapping plan that is catered to that patient. And so because of that, again, you get a very reproducible effect. If you see that at the top part, your prostate is obstructing, at the end of it, you have a big, wide open channel. And at the end of the procedure, you can see exactly what you removed. And that is, again, so different, but that makes the results very reproducible. No matter who your surgeon is, you really can get the same results because everyone's goal is exactly the same. And you should have this kind of triangular shaped defect at the end of every single procedure. And again, I'm not going through all of this, but this has been now well studied. This went against the TERP, it went against even HoLEP, et cetera. And again, the beauty of this is that it has significant improvement in your urinary symptoms, which is the purpose of all of this. But about 90 to 95% of the time, it actually preserves your antegrade, your sexual function, because you can preserve the relevant anatomy there. And again, it's durable. At the 5-year data, it beats the gold standard. So you generally, because again, that you see exactly what you're resecting, so the chance of you needing retreatment is a lot lower. And again, I don't need to go through this, but no matter if you're doing it from the clinical standpoint and you use things like how fast you flow, your IPSS, that score improvement, how much you hold in your, no matter what criteria we use, it is very, very reproducible in all sorts of patient populations, little prostates, big prostates, median lobes, etc. And so it's with this that I think is most relevant, but certainly most exciting to say, like, hey, where have we come? And is there a relevance to the active surveillance population, right? Is to say, well, if we can plan out your prostate in real time and we can use an ultrasound and we can map out your prostate and we can say, well, we can, treat your urinary symptoms in every man, even if you don't have a lot of symptoms, even if you have more minor symptoms, can we use that same water jet to treat cancer? So again, very different than the focal therapy, right? So focal therapies that I think this group has heard about is to say, well, I can see your cancer on an image, and I'm going to go after just that area of that cancer with whether that's HIFU, whether that's IRE, freezing the prostate, cryotherapy, etc. Because if I treated your whole prostate with any of those technologies, then I'm going to induce side effects. But if I just focally treat it, you should be fine. I may treat your cancer and you will, continue to do well. Aquablation says, well, you know what? I can see your cancer, but on the other hand is, why don't we just get rid of all of that tissue there because it's there for the taking, and I know that I'm not going to induce increased risk of erectile dysfunction. You're not going to leak urine afterwards. There's a 0% risk if you cough or you sneeze after this procedure that you would leak urine. So because of that, we started to do aquablation among men in active surveillance. Now, in full disclosure, this was a very select population, right? This is a population of guys that I initially saw, and I said, well, you are on active surveillance. I truly believe you were diagnosed with a low risk prostate tumor because you have urinary symptoms, you have a big prostate, we really need to treat your urinary symptoms. I don't really care about your low risk prostate cancer. Let's just do the right thing for you and give you a procedure here. So we really did this because guys had urinary symptoms and they just coincidentally just so happened to be on active surveillance. And so, again, showing you how that treatment with aquablation has evolved. If this on the left is your prostate, you can see a solid ball here. Is that what we do now is that we use aquablation and we go all the way out from the inside basically to the very periphery, the shell of your prostate, the peel of your prostate, and we get rid of all of that tissue. So you're left with just a empty shell of a prostate. Again, very different. And we did this because they had urinary symptoms initially. And again, this is just showing a different view of the same thing. It's just saying, hey, how are we creating this big channel? These guys can obviously pee a whole lot better because there's none of that obstruction here. This is your bladder on the left. This is a hole that we created on the right here after that aquablation procedure. And so when we looked at this and we said, well, how does aquablation affect these men? And again, so what we did was we took 3 different populations of guys. We took guys who were on our normal active surveillance protocol. These guys had low risk prostate cancer. We've been following them over time. We took those who had both um, low risk prostate cancer, but they had urinary symptoms. So we did aquablation on them. And then we also had a third group of patients that had aquablation only. They didn't have cancer. And we, just really asked the question to say, well, at the start of this, is there any difference if we do take patients who have low risk prostate cancer and we do aquablation, how do they do from a urinary standpoint? The truth of the matter is, and no surprise, these guys do awesome, right? That they have significant improvements in their urinary symptoms and their quality of life that is similar, no different to if they didn't have any type of cancer. That's not a surprise. I will also add that when you do this type of procedure, again, as I said, there is no risk that you are going to leak urine. There is no risk that you're going to have any type of erectile dysfunction here. But what we didn't really know, and again, this was the start and everything is even more exciting now, is that when we looked at their cancer, how do they do from a cancer perspective, is that even in a very short time period, in 5 years, there's over a 68% reduction in them getting having grade group recategorization over time. So their cancer doesn't get worse over time. So somehow by just getting rid of all of that tissue, including some of the cancer, if not all of the cancer, and that at-risk tissue as well, is that's influencing in a positive way how men do on active surveillance. And so really, is this the answer for all men with prostate cancer? Absolutely not. But if you take populations of men with lower risk prostate cancer, or certainly lower risk, favorable intermediate risk cancer, and say, hey, I can offer you a treatment that certainly should do no harm, right? I took an oath, I should do no harm. But if I offer you a treatment that says, hey, I'm going to, at minimum, improve the way you urinate. But if I can influence in a positive way how you do in active surveillance, is that something that we should more strongly consider? And I bring that up especially to this group is because we do know that when you look at no matter what trial we talk about, up to 60% or more of patients over time will be recategorized. And then we have to readdress that same conversation that we dreaded to begin with, is to say, hey, you have a low risk prostate cancer. I thought this would never go on to hurt you or harm you in some way, but now you have a tumor that may have some more aggressive potential. So now we should talk about definitive treatment. If there's a way to curb that natural history should we be doing that? And again, this is now really the basis of 3 different clinical trials that I'm more than happy to talk about the setup of these trials. But it is one of those where I'm very, very excited because it's truly, in my world, a marriage of 2 worlds of saying, hey, I have my prostate cancer world, I have my BPH, and now we're kind of meeting with some technology in the middle. So certainly with that, I'm going to end here saying, hey, if you have urinary symptoms, don't, number one, think if you have low risk prostate cancer that your urinary symptoms are any sign that your cancer is getting worse, or that the urinary symptoms are because of your cancer. 2 is that if you are bothered by it and it is impacting your quality of life and you're exhibiting avoidance behaviors, I'm looking for bathrooms all the time. It takes me forever in the middle of the night to get my urination out. Talk to your urologist. There are many, many treatments for you that can help with this. So with that, I'm gonna close because I probably already overspoke my time, but that only speaks to my passion for all of this. But certainly happy to answer any questions.
Yeah, but Brian, thank you. And you did kind of use up a lot of time, so I hope I can talk you into staying a little bit after we asked you to answer more questions.
Sure.
But I'm going to ask a couple questions first. I'm going to turn it over to Bill, who has some questions, and then David and I can go through the long list of questions. You can see there's people that are passionate about you who are patients as well. Now, I got a notice about a study of aquablation from a patient up in Wisconsin, and I sent it to you. I don't know if you're participating in that study, but one of the things that bothered this patient and that I found a little bit unusual was it was a randomized trial of the Gleason score 6 people as well as the 3+4 people and I think the 4+3 people. And these patients were going to be randomized to get aquablation or radical prostatectomy. And the thing that was striking was that it seemed that some of the guys who had, low risk prostate cancer faced the potential of being randomized into a radical prostatectomy. Are we AI imagining something weird about that? Is this legit? What's the deal?
It is very legit, and the purpose really of the trial, because in order to really kind of show comparativeness, right, is that there are 2 trials that have showed, effectiveness in terms of cancer control in mostly guys with grade group 2 prostate cancer, so intermediate risk. But the point really of the trial, or at least the recruitment, is to say, well, listen, at the end of the day, as a urologist, as a surgeon, I'm talking to you, we talked about the various options, and you are a surgical candidate to treat this. We can remove your entire prostate. So again, I don't necessarily advocate, and I personally very rarely, if ever, offer surgery to a man with, kind of even higher volume, low risk prostate cancer. But there are some that say, well, listen, every core is positive. You have all these, adverse features. There's a high likelihood you're going to be recategorized. And some people may say, well, surgery is an option there. Not to put words in these people's mouth. So if surgery is an option for you, and that would be the normal thing that you would be offering that patient, then this patient may be a candidate for this trial to say, hey, you may be as an option, a candidate for aquablation. So instead of what we would call standard care therapy, there's an experimental therapy that you may be a candidate for that isn't associated with the same potential risk of side effects. So as another option, you can consider this. If that is something that's appealing to you, that you can be randomized. So that again is saying that, hey, if you choose to be part of this trial, because surgery was your other option, is to say this is another option there, that in a 2-to-1 type of randomization. So for every, no, it's 3-to-1, apologize. For every 3 patients that are randomized to aquablation, one is randomized to surgery. That you could potentially be involved in this trial. So again, this isn't meant to say, well, hey, you were diagnosed with a low risk prostate cancer on active surveillance. This is a trial that you are really going for surgery, and as another option, we're offering aquablation as a different thing. Now, there ultimately may be yet another trial or even an arm of this trial that is designed for active surveillance patients, which would not be randomized, that would say, hey, you could get aquablation as a potential intervention to see if we can curb your natural history in active surveillance. That would be different, but this one is really more for guys with generally higher risk disease in terms of the higher spectrum of the intermediate risk disease, to say, hey, you're generally a surgery candidate here, and we are going to offer this as potentially a randomized trial.
Brian, another quick question, I hope. Can you still hear me?
Yeah, I can hear you.
Okay. You talked about finasteride. I happened to hear from a patient in North Carolina who was offered finasteride, and he encountered information about something called post-finasteride syndrome, which allegedly is a linkage between that drug and depression and suicidal ideation. So, have you heard about this? Is there any merit to this?
There's a whole support group, if you will, even online, about men who have been on finasteride, etc. It's a controversial drug, right? If you look at most drugs, you will see, especially any type of hormone manipulation type of drugs, you potentially can see associations with depression, anxiety, etc. In really critical review of the literature, it's a difficult thing to really parse out because there's a lot of confounders in there, meaning that a lot of men who have urinary symptoms, um, over time, whether it's because of urinary symptoms themselves or because of other factors, cause some type of depression. So was it really the finasteride that exacerbated this or not? It's a hard thing to really kind of emphasize. In fact, there are even similar implications from those same studies that maybe alpha blockers, the tamsulosin, may have a weak association, but still a significant association in the same way. So in that way, I always put some caution there. But it is one of those where when those drugs went for FDA approval as a prostate cancer prevention drug, they got denied. And again, that's been a whole different debate. But if you look at the data, men who take those type of drugs, about 25% of them or more may actually it may prevent prostate cancer, period. So there are some benefits there, but I do think that if you're going to start a patient on this drug, finasteride or dutasteride, you should have those conversations of saying, hey, it may actually help your prostate cancer to some degree. Some data says that it may shrink it, so our, kind of diagnosis of more aggressive may be more accurate. But there may be some sexual implications that we should at least talk about. Rare. There may be some implications in terms of long-term cognitive decline or depressive, suicidal ideations. So it is, again, when you look at the holistic part of a patient and knowing that, everyone's going to be around for a while, no one's going anywhere, that it is important to address that.
Okay, Bill.
Yep, I'll chime in here real quick. We had a number of questions, but it looks like most of them got answered already, so that's good. Have one specific one here. Which BPH procedure leaves the prostate capsule in the best shape for follow-on use for rectal spacer in radiation therapy, Rezūm or HoLEP?
Uh, just wait, repeat that first part of it.
Okay. Which BPH procedure leaves the prostate capsule in the best shape for follow-on radiation, Rezūm or HoLEP?
So Rezūm generally, if you're going to compare those, will have the least amount of impact, especially if you're going to do surgery, because it generally any type of water type procedure doesn't evoke or impart any kind of residual energy to that remaining prostate tissue. So there's generally not the scarring there. HoLEP itself, because it uses a laser, does impact the amount of scarring there. So it can be a little bit tougher if you're talking about surgery because of that. And so certainly preservation of nerves for erections and stuff. If you do surgery after a HoLEP or you do surgery after a green light, it's not impossible by any means, but it certainly can be a little bit more scarred in. In terms of radiation, a lot of these procedures are actually done prior to radiation. So if you have urinary symptoms and they say, well, listen, radiation itself can induce a lot of urinary symptoms. Because your symptoms are so severe, we want you to do some type of procedure on your prostate before we do that. All of these things can help, and it generally doesn't make a difference which one you choose. It just depends on your impact and how fast you recover, so to say.
Okay. I have a quick question here. Is BPH hereditary?
BPH is BPH is very common. We generally say that about 85% of men over 80 will have, some degree of urinary symptoms because of an enlarged prostate. So yes, it is very common, but certainly when you look at the hereditary part of that, it is considered actually one of the most hereditary. I don't even want to call it diseases, but diseases that we know of. Actually, up to 68% of it can be attributed to kind of hereditary components or more. So very, very hereditary. So if your father had it, and that's what I warn my patients, make sure and talk to your kids about it because your sons will likely have an enlarged prostate as well.
Okay, that's good. Well, Howard, how about if we jump into the chat questions?
Okay,
Can I ask a couple before we go to chat?
sure.
Okay, thank you. I'm part of the chat. Doctor, thank you. Incredible presentation. Fantastic. I'm very interested in this aquablation, and what you're saying is you're taking the pulp out of what would be considered the transitional zone. Is that what you're saying?
For routine aquablation, for just urinary symptoms, that's what you resect. So you get rid of the pulp part, and basically resect to the peel. Except at the very top of your prostate, you leave that tissue because that's where your ejaculatory ducts come in.
Question: if a patient has a suspicious lesions in the transitional zone that's causing them to get an MRI PIRADS 4 or 5, will that tissue be removed in the aquablation since it's part of the transitional zone? And then will that cause the MRI PIRADS score to go down?
So again, this is all, if you will, considered experimental, but certainly of those patients who have had what you are describing now, typically the answer is yes. So subsequent MRIs, subsequent biopsies, et cetera, are all negative. And again, it depends on how extensive you resect and if you include all of that in your planning, so to say. The other potential, and again, the caveat there is it's still in the experimental realm, is that a lot of the patients get to a point because your PSA or related tests all significantly lower, usually to non-cancer levels. Your MRIs are all negative, that the intensification of the need for subsequent biopsies goes way down, right? Because what are we doing? There's nothing that's suspicious. There's at all. So we kind of monitor you, but it's really in a de-intensified fashion. So another potential, if you will, advantage of this. But, you know, because it is kind of nuanced and these trials have been going on for the past 3-4 years now, we can't really comment on the long-term effectiveness of this. But it appears that there's no, you know, kind of harm, if you will, in the process of this. And even if, let's say, the procedure didn't work, it doesn't cross off any other possibilities for surgery or radiation because, again, it's a water-based therapy and there's no scar tissue there.
Thank you. This is pretty exciting. I want to follow up on that. So if someone has a biopsy from the transitional zone and it shows a Gleason 3 or a Gleason 4 or maybe higher, will those cells be removed so that there's no Gleason 3 or 4 or 5 to grab from the transitional zone because it's been aquablated out?
Correct. And by the way, is that the other beauty is, so the answer to that is yes. We know that it not only does that, it doesn't spread cells in the process or anything like that, but you can also use this to get out to the peripheral zone. So it is one of those where this is unlike HoLEP, where you're limited only to the transitional zone. This gets to the true outer part of that prostate.
So David, we need to get some of the chatters involved in this. If you want to pull them up, or should we ask
No,
them?
go ahead. I was going to, no, you can go first, and I was going to just start. It's a long list, so I was going to start from the top down, but go right ahead.
Hey, I'm looking from the bottom up, so to speak.
Okay.
This is experimental, so what you've been talking about. So this is really not an insurance issue at this point.
That's a very evolving target, right? So if you have urinary symptoms and coincident prostate cancer, most insurances will cover this for the treatment of your urinary symptoms, not as a cancer treatment. If you have Medicare, Medicare says you have, you know, no matter what type of cancer, low risk cancer, you cannot get this because they haven't changed their guidelines to say, even if you have urinary symptoms, that you can get aquablation. That is evolving, but it is one of those where Medicare is the only one right now that holds that they won't approve it if you have any type of cancer.
Okay. I'm trying to find, there was a question from one of our Canadian viewers, if you will, if is this television? I don't think so, but although you've been talking a lot about streaming one way or the other.
This is a lot of streaming,
But he asked if this aquablation is available in Canada. I think the answer is yes.
It is. So there are several sites, Toronto, and where is now Kevin, that I know have it up there. It is not part of the covered national system as of right now. And so because of that, either it has to be done as part of a study in Canada, or I know, as an example, Kevin Zorn, because he's the most vocal, has essentially a private part that, you know, he regularly offers it up there. So, you know, the implementation and change in a national system is very different than the US, but I do know that it is something that is being discussed actively.
Well, this seems to be a hot question amongst the Canadian audience, because I see about 3 guys from Canada are asking about this. Think Niagara Falls. We share a border. Now, Phil Siegel from Toronto said, are there many urologists using aquablation for full removal of prostate tissue in men with low risk prostate cancer? He's from Canada, but I think he's talking about overall.
So there are, as part of the Water 4 trial, as an example, and again, what's happens off protocol, I can't comment on, but there's over 44 different sites. So in that way, there is a increased number that is doing it. In terms of just for routine BPH, there are now hundreds of sites throughout the U.S. that offer this. So what was more in the experimental is now, kind of permeated throughout most states in the U.S.
Is there a centralized place people can find out about this?
So if you go to the Aquablation website, and I don't know how comprehensive or not, I've actually never used it. But if you go there, it actually has a listing of, kind of experienced surgeons on there. So you can definitely find out more information. And I know that if there's questions, you can directly contact them and they have someone reach out and can refer you to, kind of a higher volume center that's near you.
David, how about you take over for a bit?
Okay. I have a question from Israel Garza. Do BPH procedures affect PSA density calculations, or does the PSA density calculation already take previous BPH procedures into account? In other words, when you reduce the interior through aquablation, for example, you're taking out some volume of the. So maybe you could tell us about.
Yeah, so the answer is yes. Actually, everything seems to go down. So your PSA goes down after these procedures, and your PSA, your prostate volume will also decrease. So after a standard BPH procedure for whether that's HoLEP, whether that's TERP, whether that's aquablation, you're in general going to see a volume change about 30 to 50%. After the so-called cancer aquablation thing, that's about 90% reduction. So when you calculate your PSA density, that's going to be very different. And we don't actually know how to truly calculate that volume because we're still in those calculations assume a solid ball. But obviously, not only does the overall volume change, but now it's a smaller but hollowed out ball. So it's even lower. But certainly it does make subsequent interpretations of PSA and related biomarkers actually a little bit more accurate because you are removing a lot of the confounding, kind of benign PSA producing tissue there. So it is actually easier to interpret and certainly monitor patients in that way.
Terrific. Another question. Thank you. This is really exciting. What's the standard recovery protocol following an aquablation?
I always say it's about 2 weeks. You're very functional during those 2 weeks. It's not like there's a lot of downtime. Certainly, we don't want you doing heavy lifting or running a marathon during that time. But in general, we say 2 weeks because we want you drinking copious amounts of fluid, so about 2 to 3 liters of fluid a day, because you do see blood in the urine. So we want you to flush that through. We generally tell you to take some type of anti-inflammatory, whether that's ibuprofen, whether that's Celebrex, something like that, just because when you burn, there can be some slight, burning sensation at the tip of the penis. But again, it's something that one of my partners studies quite a bit is the patient experience. Again, comparatively to most other type of BPH procedures, it generally is easier just because, again, that it uses water. And that doesn't evoke a lot of the type of irritative symptoms that a lot of the other procedures offer.
I had an acquaintance who did have aquablation. He loves it. Went from 4 nocturia down to 1. And he did say he was on a catheter for about 5 weeks following that. But he's very happy post that time. Is that unusual or?
It is unusual, and my suspicion is he was having a lot of problems before the procedure. So sometimes
Okay.
getting his bladder back conditioned to appropriate would be is variable. You know, most guys, as an example, have a catheter overnight. That's it.
Okay.
Uh,
Wow.
but the again variability, but the average is going to be about a day of a catheter throughout the world, so to say, if you do aquablation.
I think a lot of us might be interested in aquablation after this talk. So,
I-
how do we, in your opinion, how many do you have to do to achieve expert level?
So that's the other thing is that you know, one of the things that we compare it to is that if you were learning TERP, which is about, you know, 50 to 60 cases as a surgeon learning curve. If you do HoLEP, the holmium laser enucleation, that's about, you know, generally even after 200 you know, surgeons are still learning for this. We generally say between 10 to 20 cases, and you should have a basically almost expert level in terms of your aquablation. So it is one of those where it truly has democratized everything, because if you can see it, if you can use a computer to plan out and execute, it has made it a lot easier for most surgeons to quickly adapt to the technology.
Thank you so very much. I'll turn it back to you, Howard, while I look at the chat boxes.
Okay.
Hey,
We,
Howard. Howard,
yes,
could I jump in with just a couple quick ones that I uncovered here? Uh,
sure.
Doctor, does having BPH a long time cause permanent bladder damage?
It, the answer is mixed. Yes, there can be some damage there, and certainly that, you know, what we worry about is that, again, as guys, we sometimes wait until it's sometimes too late, although that's very rare. Usually, even for it really, if you so advanced cases, you know, we worry about the bladder decompensating, right? At some point, it just builds up so much muscle, and then it basically just poops out. So that's really those guys that you worry most about. Even those, if you still do an outlet procedure, you usually can get, you know, a significant recovery. But certainly the earlier you can kind of preserve your bladder health, right? And so there's this concept of saying that the earlier that you can intervene, the happier your bladder will be. And so your bang for your buck, right? If you take and unfortunately, there's very few studies that have really shown it, but of the studies that we can parse out, is that if you intervene earlier, if you're a 60-year-old and you have an outlet procedure, the amount of improvement is going to be is more than if you're 80, because the plasticity, the ability of your bladder to kind of relearn, is going to be greater as your tissues are healthier. That's the overall kind of thought there. And that's really where we worry. We saying, well, yeah, what did we do? We just gave you a medicine. It delayed a little bit, but did we really make your bladder happy? I think that's a, you know, kind of an evolving question. But in general, that's where we try to emphasize is saying, hey, if you're seeing the symptoms, talk to someone. See what options there are.
Okay. Boy, you've touched a nerve here, I think.
That's good. Love it.
Um, so the questions just keep coming up. Okay, do procedures like aquablation or PAE result in elimination of medications such as, oh, I don't know, finasteride?
Finasteride and so that's really the goal period, is that if you're going to do a procedure, you get off your medications. And that's really when I say durability or variability here, is that your resective technologies, the aquablation, the HoLEP, the TERP, the, you know, where we enucleate, those are going to be the ones that, you know, give you the highest percentage of just totally staying off medications, period. Again, another advantage there. So I typically say if you're on a medicine before we do any type of outlet procedure, you'll continue that for 1 month, and then we totally stop. You're off theoretically forever.
Okay, David in Rome. So, and that's not Rome, Indiana, it's Rome, Italy. Uh, Is there a Rome, Indiana? There probably is.
There's a Rome, Illinois, I believe. That's
Uh, he repeats Ralph's question. How can aquablation get rid of cancer? Since you said most cancer is in the outside peel, not in the center that's treated with aquablation.
because that's where you have the ability to plan. So if your prostate, you plan to have the water jet resect out to the peel. Because water can stop on a dime, that's really where you can plan it there, and you don't have to worry about it making a hole or going somewhere where it doesn't belong. Is that you truly can plan it to that shell. And that's where it is, to my knowledge, the only thing that can really get to the of the BPH technologies to that peripheral zone, because HoLEP it would be the only other contender in that space, and it really they need to stop at that transition because then they can start doing some damage with the laser.
And then there's several people who are asking what the cost is. I guess these are the rich guys who can pay.
So the cost is you know, in for the most part, aquablation is covered by insurance. Certainly, if it's not, it is going to be somewhat institutional dependent. You know, I should know this, but I think as an example, at our institution, I believe it's between 7 to 9K. I think at other institutions it can be 20K. So again, there's variability if you pay out of pocket for it. But the nice thing is these days, most insurances cover it.
They cover it for BP,
Non-Medicare for BPH.
but not for the experimental use with low risk prostate cancer.
Lower risk cancers that in general, if you're part of a trial, it's covered. If you're not, then it would be, in general, most people would just charge the institutional out-of-pocket cost.
Yeah, along these same lines, Jerry Frank asks, he asks about cost. He's one of the cost guys. But is there a danger that this will be overused by people on active surveillance and become an over-treatment-y problem? I think he intends that with the Y on the end, over-treatment-y.
Yeah, I mean, I think that's, you know, listen, I was one of the people who stood years ago to say, like, why are we doing this? If you're telling me it's a low risk cancer, what are we doing? You guys are fine. We just watch you. But on the other hand is, again, it's something that you learn over time, is to say, well, what disturbs me is the high percentage of guys who ultimately progress. And again, I don't care if you're talking about ProTech data or whatever, all the studies say that even though we're delaying treatment and you've lived and you haven't had side effects the whole time, at some point, we generally sit down and we have that conversation. Can we avoid that conversation? And I think that that's one of the questions that we're really interested in, is to say, is it over treatment, or are we overusing it if we're offering it to patients and there's kind of like a zero harm, right? And the biggest harm would be retrograde ejaculation, no fluid that comes out. But if we're not changing your erections, we're not changing the sensations, your quality of life is preserved, we're not increasing your risk of urinary symptoms, we're only improving your urinary symptoms, and we're, you know, potentially treating or at least altering in a positive way your cancer outcomes. Is that a bad thing, or can that be overtreated? I don't know if we know that. I think Indy Gill from USC I mean, he truly believes that this will change the way that we treat, you know, kind of lower risk cancer. I think the data, you know, will show itself and bear itself over time. Certainly, I'm very excited by it because, you know, I think, again, in a total nerd fashion, like, it is so fun to do and see how, you know, these patients are doing. But I think time will tell. I think time will tell.
I'm going to follow up on that. About 10% of us on active surveillance are really on anxious surveillance, to the extent that even though you know our Gleason scores look okay and we have lower risk cancers, many of us in this smaller group, want to have surgery. They're worrying about this. So would it be a legitimate use of techniques like this to treat these people? Is there an ethical issue with there?
And that's, that's what I don't know if we know, but what I can say is that again, we gather patient reported outcomes and how people feel, I think that's a lot of our due diligence. And if you ask, and I don't, again, these are motivated patients and it's certainly a subpopulation. But if you ask patients and you say, well, listen, do you feel better that you did something? That we weren't just watching you, but we actively did something that really has really an easy recovery, no harm, et cetera. You're doing better. Did that help your anxiety? And they you almost uniformly say yes, because I feel like I just was treated. I know I'm still being watched. I know there's still a chance that things could go, but I don't feel as nervous. And so is that treating something? I think that is. I truly believe that, as we go through life, I think anxiety is a real thing and it can cause a lot of bad things health-wise. And so anything that we can do to help with that, I think that's a positive. Do I think that should be our only motivation? No. I think our other job is, hey, talk people off the ledge to say that you have a lower risk cancer. We really don't have to do anything. But I do think that there is something good about being, active in this way.
And one other follow-up to that is guys who are in, well, okay, there've been similar discussions with like focal therapy, with some drug therapies, you know,
Right.
so if you put these guys on those different approaches, including this, this one that you've been talking about, is that still active surveillance? And if it's not active surveillance, is that okay?
Well, yeah, I mean that's the question is, and if we can decrease again the intensity or the subsequent need for treatment, I think that's like a without any harm for side effects. I think that's also the key here. It is what side effects and how are we impairing your quality of life? I think focal therapies have potential, but the problem again is that there's a treatment trap because a lot of failures for focal therapies are because you have disease that's persistent outside of where you just ablated, and that you all of a sudden end up having the same type of conversation over time. But if you treat with, HIFU, the whole gland, then you get the side effects. This is, something, that you move from a focal to a whole gland treatment, and then you're not really saving anything. So I think this is a little bit different because again, this is also addresses your urination. Um,
I know that, well, it's your own damn fault is what it is.
it's a lot, I have a lot of problems, Howard. You know that.
You 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 talk too long, and we got, to be blunt, a shitload of questions. And I don't know how long you want to stay in there if
I
you're.
only have to be respectful because I'm at my daughter's parents' weekend, and I should at some point pretend to be a parent, but but I also recognize that I could talk about this all day. So,
Well, that's
um,
what I was afraid of. Um, and a lot of guys were getting antsy about getting their questions.
Howard, let me just get a quick one in here.
Yeah.
What role, if any, does calcification uh, play in BPH? And is there any studies that show why that occurs in the prostate?
again, it relates to just we think. I don't even think it's the content of the prostatic fluid, but as the prostate fluid sits there, it can, kind of form calcifications. And so the presence of calcifications has been associated with the presence and or severity of urinary symptoms. A lot of people have taken them to that finding to somewhat extremes, the amount, the number, the location. We don't really know their significance at all, honestly. And my personal belief is that a lot of the calcifications actually happen more just as a function of aging and blood supply, that some of the vessels that feed the prostate can calcify there, et cetera. The truth of the matter is a lot of it's pontification and we don't really know.
Thank you.
Yeah, David.
Two quick ones. One is a lot of these procedures go through the urethra to get to, the transitional zone. And is there damage to the urethra tube in that process? And apparently, I guess it can heal fairly quickly.
Yeah.
Is that what we should understand?
So I always say that, one of the biggest misunderstandings of the anatomy of the prostate itself is that there's a separate tube or urethra that goes through it. The prostate is the urethra. So
Okay.
if you picture that you have a straw that leaves your bladder, right? And that straw, the urethra, the first part of it is the prostate. And over time, the wall of that prostate becomes thicker and thicker and thicker, right? And that's really what kind of compresses it. So when we do BPH surgery and we do a resection of that, what we're doing is we're going into the prostate, which is the tube, and then we're resecting that tissue so that opens that up. But then quickly, that's kind of epithelialized with normal, kind of tissue. So it really quickly heals itself.
Okay. Thank you. That's really appreciated. One question from the audience was, is there any connection between heavy weight and BPH? If you lose weight, can you reduce BPH?
So it's a difference of symptoms, actually. So again, confounding that is that if you have you're overweight, or if you have diabetes, or if you you can have urinary symptoms, and the reason why that is really related to metabolic syndrome. So this is again a complex interaction between the hormones, between our nervous system, et cetera, and they generally can cause you to have an overactive bladder. I got to go to the bathroom more frequently, etc. A lot of the studies on BPH and obesity or just being overweight are really more related to the fact of that overactivity, etc. When you look specifically at the associations between, as an example, prostate volume or size and obesity, it doesn't really track that well. So I think the long and short of that answer is that if you are overweight, certainly losing weight can help with some of the urinary symptoms. It doesn't totally reverse it, but certainly can help contribute to the management and severity of your urinary symptoms. So again, just like the heart, certainly weight loss is a good thing. Same with the prostate and bladder health as well.
Thank you. Back to you, Howard.
Yeah, I think we should probably call it quits after a couple more questions. I'm afraid this could go on all day.
Let's say two more.
Okay. Okay. Something pop up for you, David?
Well, a lot of questions about Flomax and things like that, potential side effects, but you did I think this may have been written before you covered it. You covered Flomax, I think, and finasteride very well in your slides. So I don't have anything on that.
The biggest risk of Flomax is really two things I always say is that the biggest risks are that you can have retrograde ejaculation, so decreased fluid when you orgasm. That can be up to about 80 to 85% of men on that. So again, guys will often say like, "Hey, I've noticed for years I haven't had it." It's usually because of that medication. And two is that there is about 15% of guys who, when they start it, can get lightheaded. Usually not a change in their blood pressure, but they can have that sensation of being lightheaded, and often, especially in older guys with other, medical issues, they can, pass out or fall. So it is one of those, when you start a man on that medication, just counsel them that if they feel any of that, stop it. There are other alternatives to those medications if needed.
Thank
Okay.
you.
Have you have you ever heard of ozone treatment of the prostate?
There I have, again, the overall effectiveness, it has never been shown, and it hasn't been rigorously studied, but using kind of free radicals to kind of help with its overall health, has been looked at, but it's certainly not considered any type of routine at this point.
And Jerry Frank, I guess we should just round robin this as fast as we can. Jerry Frank asked, will the profit motive affect how many people on AS will be offered this treatment?
Um, the very bad part of me says that it's anything is possible, because sometimes decisions are made based on what is reimbursing, and certainly when you look at BPH, historically that has been um, a big moneymaker. On the other hand, as I will say, is that based on the reimbursements, for example, Aquablation, that have been proposed for the upcoming year, it's not making anyone money. So it's one of those where I think it's theoretically in a safe spot, because when UroLift first came out, as an example, they were reimbursing really well, and people were using that just so extensively. That type of reimbursement isn't really seen, ironically, for any of the procedures that have the strongest data, any of the resective procedures.
I'll tell you what, why don't we thank you, as long as the rest of the panel agrees.
Yes.
We thank you,
Yes.
Brian.
Thank you.
And we really appreciate your taking time on a parents' weekend to spend with all of us old farts with BPH. And hope maybe you come back and share some more. But meanwhile, thank you.
It is my pleasure. Thank you. Thank you.